सर अभी भी ट्रांसक्रिप्ट आ रहा है. Welcome friends to today's webinar. So today's webinar is on imaging, and the topic today is abdominal imaging. So abdominal imaging is something which is not discussed often, and you might find it very useful. And speaker today is a very distinguished senior radiologist from NCR Delhi, Dr. Rajesh Gothi. Sir had taken a previous session on imaging of the chest also, which many of you may have seen and is there on our YouTube channel. So just to introduce sir is very senior and he did his MD in radiology from All Institute of Medical Sciences, New Delhi in 1978. And he's currently affiliated with many hospitals, but mainly Holy Family Hospital, New Delhi. And he's a member of various organizations. He is the chairman, organizing chairman for Onco Imaging Conference, and he has various publications. And he has authored a book on ultrasound, 2 book chapters for IGNU, 2 electronic modules for Elsevier, and many articles in various journals. He has received many awards, including the Distinguished Service IRIA Award 2013, GPL Award, JC Bose Award, and Ratan Award DMA. So, sir is one of our very senior radiologists, and indeed very fortunate that we are going to be hearing from him. So, over to you, sir.
Hello, good evening. Today I'm going to talk about abdominal imaging, and I hope that you will enjoy this talk and go back a little more wiser than you already are. Now, in most ICUs and most critical care people, they use X-rays very frequently. So most of them are very well versed with X-rays. But there are times when they get foxed and they don't know what exactly is happening. And my attempt here will be to help you realize or see what the radiologist can see. So beginning with this, let's go on. I'm going to discuss a series of X-rays which will be based on cases which we have seen in practice. And from those cases, we will come up with some diagnosis and discussion. And hopefully you will like it. So let's start with case number 1. This is a 90-year-old female with abdominal distension. Now, plain films show gaseous distension of the colon. What can be the causes? Now, in this, the first thing that one has to understand that one has to see is that she is 90-year-old. And she has come with abdominal distension. We've got 2 films here, an X-ray abdomen, supine and erect. We are seeing gaseous distension of the colon, but we are not seeing any air fluid levels. The distension of the colon can be seen till the sigmoid region and even till the rectum. So obviously, it would mean that there is a very less chance of there being an obstruction. So what can be the causes of these kind of findings? There are 2 main causes when you see a lot of gaseous distension. One is obstruction, which could either be physiological or due to a mechanical cause. And the second, you all know, could be an electrolyte imbalance. So in this particular case, despite the fact that the colon is distended, there is hardly any small bowel dilatation. Most of the dilatation is in the colon. Therefore, what can be the possible causes? I would say from these films that it's very unlikely to be obstruction. I'm not seeing any air fluid levels. There is no evidence of any free peritoneal layer. So I would consider a possibility of electrolyte imbalance. So this was a case of acute colonic pseudo-obstruction or OGILVIE syndrome. OGILVIE syndrome is a dilatation of the colon most of the times, and the colonic distension can really expand the colon to such an extent that there is a likelihood of perforation. So we normally take 9 centimeters as the normal maximum distance allowed. Some people have stretched it to 12 centimeters, beyond which there is a risk of perforation. So you have to measure the colonic width, and then from there, you decide whether there is a risk of perforation or not. Coming to a companion case, again, a patient presenting with pain in the abdomen along with distension. A portable X-ray was done. Now this portable X-ray, the film looks hazy, so one can say that the image quality is bad. but that is not the case. The abdomen is distended. The penetration was not enough because of the distension of the abdomen, but there is enough information in this film. So what are we seeing? We are seeing the transverse colon distended with gas. There is some amount of gas here in the left colon. There are small bowel loops which are dilated, but there is a very unusual, a funny kind of a shadow, which is sickle shaped, which you can see over here. This shadow is not conforming to any bowel loop pattern. Therefore, this is abnormal, and one wonders why such a shadow is present in the X-ray. So I will take you to the scanogram because this patient had a CT scan done. In the scanogram, you can see that the colonic loops are distended, and you are seeing evidence of air, which is free peritoneal layer overlying the liver. So this is a supine film, which is a scanogram done during the CT scan, and it shows gaseous distension of the colon along with free peritoneal layer overlying the liver, which means it is lying in front of the liver because this is supine film. Normally, air does not go behind the liver because there's hardly any space other than the presence of Morrison's pouch. So a CT scan was advised by the consultant. Now, when you send patients for CT scans, kindly write the differential diagnosis of what you have in mind. Because when the radiologist is looking at the scan or when the technician is looking at the scan, he really does not understand why the scan is being performed. I can tell you that most of the technicians are very smart and they are excellent help. They know a lot of radiology, probably more than many physicians, because they do this work day in and day out. So if you write to them that this is my possibility, they will then manipulate the study in such a way so that your question can be answered. So kindly do that whenever you're filling a request form. Now the next question is, what type of scan would you request? Will it be a NCCT scan or will it be a CCT scan? NCCT means non-contrast scan and CCT means the contrast enhanced scan. So what can be the answer? And I'll tell you what the answer would be. The next question is, will you be giving oral contrast to this patient? And what are you expecting from your CT scan? Are you thinking that you'll find something abnormal, different from what you have seen in the X-rays? So let us look at the answers. The first question will be that I want to find out why the bowel loops are dilated and which loops are dilated. And is there any free peritoneal air present or not? Because this is the most important thing which I want to find out from the CT scan. I will be doing a CT scan with contrast, but I will not be giving any oral contrast to this patient. He is already significantly distended, and oral contrast is going to take ages to go anywhere. It will stay in the stomach or maximum in the proximal small bowel loops, and it's not going to help. Therefore, I will not be giving any oral contrast at all. Now, this is the scan of the patient. You can see that I have taken two windows over here. This is a soft tissue window, and this is a lung window. Now, when you examine the abdomen on lung window, it is very easy to pick up free peritoneal layer. This is the free peritoneal layer, which you can see beneath the anterior abdominal wall. These are the dilated small bowel loops, and this is the dilated right colon. And this is the mediastinal window or the soft tissue window where it's very difficult to really make out the free peritoneal layer. It is meant to show soft tissues. Now, coming back to this image, we find a lot of air bubbles over here along the inner wall of the colon. So one can be tempted to consider a possibility of pneumatosis coli. That means you're thinking of ischemia, but that is not the case. Because when you look at these bowel air bubbles over here, they are merging with the fluid level. So when the air bubbles merge with the fluid level, it means that they are within the lumen of the colon, lumen of the bowel, and they're not in the wall. So pneumatosis intestinalis is air within the wall of the lumen, wall of the bowel, and not within the lumen of the bowel. So this is air within the lumen of the bowel and trapped between the contents of the bowel and the bowel wall. So this patient did have a perforation, a very small perforation in the transverse colon, which resulted in production of free peritoneal air. Case number 2, patient comes with pain abdomen, the bowel loops are distended with air. Question is this obstruction? Now, when you see this film, I asked my residents also whether they were thinking of whether this could be obstruction, and they kept quiet for a few minutes. not knowing what to say. But I told them that don't be worried. Your answer can at best be wrong, and at worst can will be right, because you would not have guessed the reasons why the answer would have been right. Now here, if you look at so I'll tell you why this is not obstruction, or very unlikely to be obstruction. The bowel loops, although distended with air, although filled with air, I would say, are not very grossly distended. There are fluid levels which are almost in the same plane. Some of the fluid levels are there in the colon, and some of them are in the small bowel. Such a pattern can be seen with several conditions, which can be gastroenteritis or any other, even after an enema, or after, say, diarrheal stools, or patient being on antidiarrheals, cathartics. So that what should be done in this case is that you wait and watch and see how the bowel will behave. If the patient is able to have a good bowel clearance the next day or in the evening, then your problem is solved. So just by looking at distant bowel loops, don't jump to the conclusion that the bowel loops are obstructed. They can just be having an ileus, which will result in entrapped or presence of air and fluid in the bowel loops. Their caliber will not be distended, and their fluid levels will be almost in the same horizontal plane. Case number 3. Patient again presents with diffuse abdominal pain. Now what you should do is you should note the location of these bowel loops. These bowel loops are located in the midline, in the center of the abdomen. The periphery of the abdomen, where the colon should be present, is gasless, and there is no gas in the rectal area. I hope you can see my pointer. So, yes, yeah, you can see it. So these are all small bowel loops which are filled with air. They are floating in the abdominal cavity because air is lighter than fluid, and that's why they are floating high up. And I'll show you in the subsequent images. But what is happening to the rest of the bowel? These are jejunal loops and probably proximal ileal loops. The rest of the ileal loops are not seen. The colon is not seen, which means that there is some obstruction either at the junction of the ileocecal level or somewhere else, probably in the proximal ileum. So we'll have to go in for a CT scan to see where exactly the obstruction is located. So let's go to the CT scan. An axial scan of the abdomen. Look at these small bowel loops they are filled with air. They have risen up to the top beneath the anterior abdominal wall because they contain gas which is lighter than fluid. This image over here has been boxed, and I want to show you what is called the positive fecal matter sign. A positive fecal matter sign is actually fecal residue or residue of food products which the patient has been eating. So this is mixed with air bubbles and gives an impression as if it is fecal matter. So this is seen in the small bowel loops, and when you see it, it means that there has been an obstruction distal to it, and most probably that obstruction is of some duration. It could be long-standing. So this image tells you that there is a distal small bowel obstruction resulting in presence of a positive fecal matter sign. So as you go up, this is the cecum, that is the terminal ileum. This is the IC junction, and you can see that the terminal ileum and the IC junction show thick walls. So there is thickening of the walls of the terminal ileum and IC junction, indicating thereby that there is an inflammatory process, there is a disease process which is causing obstruction. The surrounding fat planes are absolutely free. There is no fluid around them. There are no enlarged nodes. So it's a localized disease involving the terminal ileum. So let's go and see what's happening. So the next step that I did in this particular case was I took this patient up for an ultrasound. And on performing the ultrasound, I found that the wall of the terminal ileum was diffusely thickened and hypoechoic. There was loss of mucosal outline. The mural outline was not seen. The entire thing from this mucosa to the serosa was black in color, and there's a short segment involvement. There are no surrounding inflammatory changes in the fat planes. There is no fluid collection. So this was a localized inflammatory pathology involving the terminal ileum, and it exactly resembles what you see on the CT scan. So this was a granulomatous disease which was of long-standing duration and causing a positive fecal matter sign. Let's go to the next case. Now I'm showing you a picture of the pancreas, the normal pancreas. And what I have done in this patient is I've taken a delayed arterial scan. Now, the reason why I've taken a delayed arterial scan is because of the reasons that I'll give you subsequently. But what you have to see here is the pancreas is enhancing uniformly. The tail and the body are enhancing uniformly. But look at the head. The head is enhancing a little less as compared to the tail and body. Also, when we are seeing this section, we are only seeing the pancreatic head. And when we are seeing this section, which is slightly higher up, we are seeing the body and tail. This tells us that the head is at a slightly lower level as compared to the body. And when we are doing ultrasounds, it is very easy to miss a pathology in the pancreatic head. So in this particular case, there was slight difference in the density in the pancreatic head as compared to the body and tail, but there were no inflammatory changes around the pancreas. So this was a normal pancreas. And the only thing was there was a slight difference between the head and the tail. But in the absence of any other findings, it was considered as within normal limits. Now, next question. How should a suspected case of pancreatitis be prepared for a CT scan? The answer is no preparation is required. If you go back to your MBBS days, what was the preparation that was given for, what was the treatment of pancreatitis? It was nil orally. We put in Ryle's tube, tell the patient not to eat anything, watch the patient, put an IV line, at the most give painkillers and maybe some antibiotics, but nothing else, and wait and watch. So the same thing applies to the CT scan. No preparation is needed, no oral contrast is needed. Just get the serum creatinine done. If it has already been done on the same day or in the last 2 weeks, it is sufficient. You don't have to repeat it. And do a multiphasic study with intravenous contrast to evaluate the pancreas. Now, why should you be doing a multiphasic study? The purpose, and before that, let me say, why should you be doing a CT scan at all? In our country, we do a CT scan for pancreatitis because we want to confirm the diagnosis. That's a very bad thing to do because the confirmation of the diagnosis should be clinical and based on lab findings, and at the most an ultrasound finding. A CT scan done very early during a case of pancreatitis may be completely normal, or the findings may be so subtle that you may not be able to pick them up. It's a waste of money. On top of it, acute changes of necrosis take some time to develop. So what is recommended is that you should wait for at least 5 to 7 days before you get a CT scan done. But that does not happen practically because the clinician wants to ensure that pancreatitis is there. And sometimes when the radiologist cannot make a diagnosis, the clinician will come and say, you don't know how to make a diagnosis of even pancreatitis. So unfortunately, that is the situation. But still, so when the pancreas is to be examined by a CT scan, look for evidence of pancreatitis and look for complications. So I look for complications because pancreatitis is a done deal. Even a plain film will tell you that there is pancreatitis, you will get a colon cutoff sign. So I look for vascular complications, any evidence of any collection, small or large, and any evidence of any gas and any other finding which can mimic pancreatitis. So this is my reason why I should be doing a CT scan of the pancreas. So here you have the pancreas. This is a case of mild acute pancreatitis. The pancreas looks almost reasonably normal. But what we are seeing is a small quantity of fluid near the tail in the anterior paraneal space. This tells you that despite the pancreas looking normal, there is inflammation and the inflammatory fluid is around the pancreatic head. So you can give a diagnosis of pancreatitis and then watch the patient. So when I'm doing pancreatitis cases, I do a protocol. My protocol consists of a plain scan, though although this is not necessary, because plain scan does not help very much, but it is sometimes included because you can have surprises. The diagnosis may be wrong. There may be free peritoneal layer. There may be some calcification which can be mistaken for blood. So a plain scan is done, and I do it on a very low dose, so it's quite okay. But then after that, I do a delayed arterial, a venous phase, and a late phase. So a delayed arterial, I confine only to the pancreas, the venous phase, and whenever I do the late phase, includes the entire abdomen. So in this way, I can pick up evidence of necrosis. Look at this area. Its density is lower than the tail. Here again, you have the body. The density is lower than the tail. And this is the head. It shows fuzziness in fat of the surrounding fat planes. And you can also see thickening of the geroidal fascia and fluid in the anterior parallel space. So in this particular case, there was evidence of pancreatic necrosis, which was localized to the head. So that is a good information to give. It also tells me at this point of time, the kidneys were normal. Because in pancreatitis, there can be multiple organ failure. And you know that at the beginning of the disease process, the pancreas was normal. And later on, something can happen to it. So here again, something which I do is that if I have to follow up these cases of pancreatitis during their hospitalization time, I do not repeatedly give them IV contrast because that can damage the kidneys and the patient can go into AKI. So to prevent the patient from going into acute kidney injury, I give contrast only at the time of admission and not subsequently. I can give contrast if there is a cessation of a bleed, if the hemoglobin is dropping. In that case, to look for a bleeder, I might give contrast, but not otherwise. So I just restrict my contrast to the first time when the patient comes in for the scan. Now, here's another patient suspected to have pancreatitis. A scan was obtained, and what we are seeing over here is that there is a lesion involving the pancreatic tail. So one would be tempted to think that this patient who has come with abdominal pain has got a focal pancreatitis. But it's very important to look at the entire study before you come up with this diagnosis, because sometimes focal pancreatitis can develop with an underlying mitotic process. So here in this patient, there was focal pancreatitis, but there were multiple mets in the liver. So focal pancreatitis had developed on a underlying pancreatic CA, and there were liver mets. So this patient will generally not present with abdominal pain or will have mild pain, but he can have many of the symptoms like he can have weight loss, loss of appetite, and pain which is focal. And you can then suspect that it's not a simple case of pancreatitis. Sometimes, people think that ultrasound is of no value and they sort of ignore ultrasound. But to my mind, ultrasound is a wonderful investigation to do despite of its being, neglected. For one reason, it can tell you whether there are gallstones or not, whether the intrahepatic bile ducts are dilated or not, whether there is evidence of dilatation of the CBD, and it can also pick up pancreatic abnormality. So here in this case, not a case of pancreatitis, but you can very clearly see that there's a mass over here, over the pancreatic body. It was actually showing fine internal echoes. The Doppler showed that the vessels were completely normal. This was a case of pancreatic CA. Pancreatic carcinomas are hypoechoic in appearance and are distinct lesions, different from the diffuse lesions which pancreatitis produces. A companion case, this was a patient who had come with a pancreatic head enlargement. And the question was, is it focal pancreatitis? Some people have thought that this is focal pancreatitis and others have thought it's a pancreatic CA. So now how do you distinguish between the two? It is very difficult. Sometimes you can't. But I think the most important thing is to take the history. What happened to this patient? Is he an alcoholic? Does he take alcohol? Did it start after a bout of alcohol binge or suddenly? Or does he have pain going to the back? Has he lost weight? Has he lost appetite? And he doesn't seem to have any intrahepatic bile duct dilatation. So what kind of pancreatic CA will produce a mass but no intrahepatic bile duct dilatation? Therefore, these things tell you that this is not a pancreatic CA, this is focal pancreatitis. And luckily, this patient did turn out to be focal pancreatitis, and ultimately he recovered, and with our lesson not to drink again, too much again. Now, this is another quiz case for you. An elderly patient comes into the hospital with abdominal distension. What do you think that the plain films are showing? I'll give you a moment to ponder over it. The plain film, they are really fantastic. If you just pay some attention to them. Now, these are X-ray abdomen supine and erect. What we are seeing here is there is a soft tissue shadow. which is pelvic-abdominal location, which is displacing the bowel loops up. The stomach is all right. The caliber of the bowel loops is normal. It's a round, very well-defined soft tissue shadow. And think about it, she's an elderly patient, abdominal distension. So the first thing that would come to the mind of a gynecologist would be ovarian tumor. The first thing which a urologist will think will be maybe bladder. And out of the two, whom do you think will be right? So because both of them cannot decide, the patient comes for an ultrasound. So when I see this patient, when I saw this patient, all that I did was asked her, when did she pass urine? She didn't remember, and her family members didn't remember when she had passed urine last. And it was a simple case of over-distended urinary bladder, which the elderly lady could not tell to her family members, and she kept on distending. The gynecologist thought it's an ovarian tumor, but the urologist was right. Although I don't know how he made the diagnosis because this was not ballotable, but still he was right. Sometimes, in practice, you'll get a lot of cases of liver tumors, liver abscesses. Now, very often you will find that the ultrasonologist is confused and he's not making up his mind that whether this lesion over here in the liver is an abscess or whether it is something else. And generally, the tendency of the clinician is to say, these people don't know how to do ultrasound. The problem is, that's not the case. You are seeing here a lesion. It is not shouting out that this is an abscess. Many patients with abscess do not give a history of fever. They may have pain, but the pain can happen with anybody. And fever can also happen with infections and malignancies. So what you do is, when you see this kind of a hypodense lesion or a hypoechoic lesion, you always look at the chest. If the diaphragm is elevated, if there are lung lesions, which are reactive lesions in the chest, almost invariably it will be an abscess or an inflammatory pathology. Most tumors do not push the diaphragm up and do not cause reactive changes in the chest. If you find reactive changes in the chest, if you find that there is elevation of the diaphragm and the diaphragm shows restricted movements, make sure you can go ahead and say that is most likely an abscess. And even then, if you are not sure, you can sometimes even the CT will not be able to tell you between the two. So in that case, you'll have to put in a needle and you'll draw out pus and the question will be answered. This was a patient who had come for an ultrasound. There was a multilocated lesion in the kidney, in the right kidney. And one of the opinions was that this could be a hydrated cyst. Again, it is very, very important to look at the patient as a whole. The patient had acute chest wall infection and there was a history of UTI. So why think of a hydrated cyst? So I said, well, this can't be a hydrated. These are not like daughter cysts. This is a multiloculated abscess. You can see fine internal echoes within the abscess. The septa are very thick. They are not like the septa or the borders or the edges of daughter cysts. The classical case of a renal abscess, secondary to a chest wall infection. So, you have to correlate the radiological findings with the CT findings. And sometimes, you have to really put your foot down and say, this can't be a cyst. There's no point in doing any hydrated serology in this patient. So this patient's abscess was drained and subsequently the patient recovered. But not before the clinician got an MRI done. They got an MRI done, they did everything. And then at the end of the day, they said, well, yeah, you were right. This was an abscess. I thought this was a real waste of money. Now, plain films tell a lot. I'm showing you a chest X-ray and I'm showing X-ray of the abdomen with a tube. Now, if you look at the chest X-ray, the diagnosis will be very simple for all you clinicians. You'll call it a subphrenic abscess. So the X-ray abdomen helps by the fact that you can see that the collection is reached almost till the pelvis. You can see this soft tissue opacity over here, compressing the bowel loops, and the collection reaching till the pelvis because the X-ray has been taken in the supine position. And that's why the chest tube was inserted in the right iliac fossa to drain out the abscess. If the chest tube had been placed in the upper chest, then possibly only air would have been removed and the fluid would have remained in the right saphenous space. So the clinician took the right decision to put in the chest tube in the RIF. Another case, you can see that the X-ray abdomen supine have been done. There is a large air fluid level over here, seen in the X-ray abdomen erect, and this is the X-ray abdomen supine. Now, do you think is the collection? Is it in the stomach, or is it in the colon, or is it outside? Collections in the abdomen can be either in the hollow viscus or outside. It's very simple. So, if it is in the hollow viscus, it will take the anatomical disposition of that viscus. And if it is outside it, it will look like anything, but not the bowel loop or the stomach. So, if you look at this collection over here, you can see that it is walled off. You can see that the collection is walled off, and there is a shadow over here. I'll magnify it for you. You can see that this collection over here is compressing a shadow over, which is close to it, and that is the compressed stomach. So obviously this collection, the left saphenous space, is outside the stomach. The colon has been pushed down. It's a left saphenous abscess, which is a rather unusual sight, but can happen. But if you look at the X-ray abdomen, it looks as if the whole thing is the stomach, which is over-distended with fluid. And somebody can think of a gastric outlet obstruction. So, by looking at the X-rays and analyzing them carefully, you can easily make a diagnosis as to where this collection is and what is the most likely cause. It could be from a perforation somewhere in the viscus, and which has resulted in a subphrenic collection. That arrow shows here the stomach. Now, this next case, patient was admitted with fever and uncontrolled diabetes mellitus. Lab results were awaited. And since the lab results were going to take time, the patient was referred for a non-contrast CT scan of the abdomen. What do you think could be the CT diagnosis? I'm showing you two sets of images. One is taken at the level of the kidneys and the other at the level of the bladder. Patient has got fever, uncontrolled diabetes, lab results are awaited, and non-contrast CT scan has been done. So the two sets of images at the level of the urinary tract show you a finding which tells you the diagnosis. If you look at the space around the kidneys, you can see fat standing. And if you look at the fat planes around the bladder, you again see fat standing. This means that you are looking at an inflammatory process involving the kidneys and the bladder. So there's a case of urinary tract infection, which could be diagnosed even before the results of the lab came in. Case number 14, X-ray abdomen supine and erect. You are seeing multiple fluid levels, distended small bowel loops in the mid-abdomen, very little distension in the periphery. The stomach is empty. What do you think this is? Is it obstruction or is it ileus? Now, one of the things that you must always look at is the fluid levels and the air column. The fluid levels are at different horizontal planes. They are not in the same horizontal plane, and the column of air is larger than the width of the fluid. So you are looking at what? You are looking at small bowel obstruction, because the fluid levels are shorter than the air levels and the planes are not the same. Therefore, you are looking at a case of small bowel obstruction. There is no gas in the colon. It has to be distal small bowel obstruction. Another case, multiple fluid levels, again at different levels, planes, predominantly small bowel, but there is some amount of gas here in the colon with fecal residue. So these are the cases where you may have a problem on the plain films, and you may not be able to make this diagnosis. You may not be very certain of the diagnosis, but different fluid levels at different planes indicate the ongoing peristaltic activity, and that peristaltic activity is hyperperistalsis and will always be seen with obstructions, not with ileus. Therefore, this again is a case of small bowel obstruction. 20-year-old female, very strange, came with severe abdominal distension. Question is it small or large bowel? Is it ileus or obstruction? The answer is straightforward. It is not the small bowel. It is a total anatomical description, periphery of the lung, transverse colon, sigmoid colon. It is large bowel. But there is a fluid level which is in the same horizontal plane. So therefore, it is not going to be an obstruction. It is going to be a pseudo-obstruction or OGILVIE syndrome. The interesting thing was this girl was only 20-year-old. And why she developed this was surprising. She had severe electrolyte imbalance. I do not remember the cause, but that is what led to the distension of the large bowel loops. Companion case, there are multiple small fluid levels seen in the colon. So is it normal or is it obstruction? It is not obstruction because small fluid levels can be seen even in gastroenteritis. It can be seen with the administration of enema. And the colon is not so dilated. The dilatation is within the normal range of 4 to 6 mm. You can easily see the hostile pattern, which is well maintained. So therefore, this is not obstruction. It is just retention of fluid, possibly due to severe colitis. And that's about all in this particular case. The patient does not require any immediate intervention or investigation. Wait and watch would be the right thing to do for this patient. Next case, 58-year-old female came with abdominal pain following a meal. What are the findings and what is the pattern called? Now, if a patient comes with pain in the abdomen following a meal, one would think of postprandial pain, possibly due to vascular occlusion. So in these cases, you would think of obstruction. And the pattern that we are seeing here is called the step ladder sign. So I'll show you what the step ladder looks like. On the X-ray, this is the step ladder, 1, 2, 3, and 4 steps. And in the CT scan, you can see the first step, the second step, the third and the fourth step. The first step is filled with air, and the last step has only fluid within it. So step ladder sign is diagnostic of small bowel obstruction. This patient was admitted in the emergency, came with abdominal pain. An X-ray abdomen supine and erect has been provided. So when the physician saw it, he made a diagnosed small bowel obstruction and then asked for a chest X-ray. And he was surprised to find that there was free peritoneal air beneath the right dome of the diaphragm. Now, there's nothing surprising about it. If you are looking for free peritoneal air, the best way to look for it is to take a chest X-ray, not an X-ray abdomen supine or erect. This is because when you're taking an X-ray abdomen erect, your X-ray beam is centered over here. And from here, it goes up like this and down like this. So when it goes up like this, the gas shadow falls over the air-containing lung, and the gas is not seen very well. But when you do a chest X-ray, so when you do a chest X-ray, the X-ray beam is centered over here. The beam goes like this and like this. So when it goes down on the like this, the gas shadow falls over the soft tissue shadow of the liver and becomes visible. Therefore, if you want to diagnose perforation, ask for a chest X-ray, not X-ray abdomen supine and erect. You will be lucky if you can make a diagnosis of perforation based on an X-ray abdomen erect. If there is a large amount of gas, or if the film has by chance been centered a little higher up, but otherwise you will not be able to see it. Next case, patient comes with pain abdomen. X-rays were done on the same day. You got two films. This film here, which is X-ray abdomen, and a chest X-ray. The diagnosis is written in this film. you are seeing what is called the colon cutoff sign. The space between the stomach and the colon is increased because there are inflammatory changes here in the region of the transverse mesocolon. And the colon cutoff sign indicates ileus because of underlying pathology. In this particular case, the diagnosis is very clear. It is acute pancreatitis. The X-ray abdomen is very important because it shows you extensive pleural reaction and reactive change of the chest. As I told you, any inflammatory pathology in the abdomen can have repercussions which can be seen in the chest X-ray. Tumors generally won't do it. They will involve the chest only by metastasizing, but not like this. So here you have a case of acute pancreatitis with reactive effusion affecting the chest. This was an 18-year-old boy, 12-year-old boy who came with a history of road traffic accident. There was a subdural hematoma over here on the left side, and the stomach was grossly distended. So what happened was that the patient had a severe injury, and following this, he developed acute post-traumatic dilatation of the stomach. So this is an uncommon consequence or a complication of road traffic accident, but it can happen. And this child therefore needed immediate decompression of the stomach. Otherwise, it could have caused necrosis of the gastric mucosa and at unborn. The same finding was visible in the X-ray also, but the interest was mainly in the head at that time, so people didn't look at it carefully. Next case, whenever you come across a case of road traffic accident, the request comes for e-fast. Now, if the e-fast is positive and the patient is stable, you can take the patient for a CT scan. But if the e-fast is positive and the patient is unstable, he should be taken for a laparotomy. So this patient was relatively stable and he came for a CT scan. So again, we do multi-physics study in these kind of cases. There's a plain scan which shows dense fluid in the abdominal cavity, indicating hemoperitoneum, and the arterial, venous and delayed phases, we find that there is evidence of splenic trauma with fluid in the perisplenic area. So a case of splenic trauma resulting in contusion of the spleen and production of hemoperitoneum. So a multi-physics study should be done in those cases where there is severe trauma and an e-fast is positive, as well as the patient is stable. If the patient is unstable, go in and do a laparotomy rather than wasting time doing a multi-physics CT scan. And next case, probably the final case, similar to the previous case that I've shown, any patient coming with acute massive GI bleed must have a multi-physics study because one doesn't know whether the bleeding is from the artery or the vein, and in what sequence one will pick up active bleeding. So here we have a case, there are multiple diverticula. You can see the accumulation of contrast in one of the diverticula and then spreading of the contrast within the lumen from that in the delayed section indicating active bleed. Similarly here in the arterial phase, you can see the collection coming out of the vessel within the diverticulum, then spreading into the lumen of the bowel and finally opacified the bowel loops. Look at the unopacified bowel loops and the opacified bowel loops subsequent to the leakage of contrast from the site of leak within the diverticulum. So therefore, these kind of cases require multiphysics studies. They should be planned and done. They should, if they are to be done in the middle of the night, make sure that somebody is there to supervise it. And if the patient can wait, let the clinician come or the radiologist come and have a look at the case and take the plan, or bring in the best technician that you have in the department at that time and tell him what exactly you are looking for and what exactly you want to see. And then you get the best study for that particular case. So in conclusion, clinical skills are very important. Clinical data is exceptionally important. Collaborate with the radiologist, and on collaborating, you'll get the best possible results. I know plain films are very challenging, but they are very interesting, and they are really, jigsaw puzzles which you need to solve. They give a lot of exhilaration, a kick to the radiologist, because if he can diagnose from the plain films, virtually he must be a terrific radiologist to be able to do so. So with that, I come to the end of my talk. I do hope that you enjoyed it and you will enjoy it. If there are any questions, I'll be glad to take them right now. Thank you very much. Over to you, Dr. Tabesh.
Thank you, sir. Thank you so much. So can you just stop the share screen?
Yeah.
So I request the audience, if there are any questions, they can please put them up. We'll answer, sir will answer them. So just before we end it, sir, and wait for the questions, a couple of things from my side, which would be of interest to everybody. Now, in the ICU, sir, one often has to look for perforation, and gas under the diaphragm is an important thing. Now, ideally should be in a supine, in a semi-erect position, right? The X-ray should be taken chest X-ray. But sometimes patient is on the ventilator and it's not possible to make him even semi-erect. So what if you make it supine, is it reliable at all, or what do you see?
Yeah, that's a good question. If the patient is, you are not able to make the patient stand or semi-erect, do a translateral view, which means take an X-ray from the side. Keep the cassette on the other side and the X-ray film beam on one side. Generally, you will see the air between the anti-abdominal wall and the liver surface in the translateral view.
Right. But in the supine film, you won't be able to see.
The supine also you can pick up. They are called regular sign. There are different signs which you do, but for that you require a larger amount of gas, and then you have to know what to look for. You can see the ligament of Teres outlined by air on both sides. You can see air on both sides of the bowel loops. So these are the things which you look for. You can see air in the Morrison's pouch. So these are things which you can pick up if you are experienced. But otherwise, a translateral will show even a small amount, as less as 15 cc's of air in the abdominal cavity.
Right. So then other thing is, what about, sometimes when you patient with pancreatitis, acute pancreatitis, so he goes into kidney failure, creatinine goes up, and you do a CT after, not immediately, but after 5-6 days, creatinine has gone up. So here, giving ideally one has to do CCT to pick up necrosis and all these things. So contrast is a problem with the patient is already in AKI. So books and literature advocate MR. MR is pretty good for this severe acute pancreatitis and picking up necrosis. So is it okay to do MR?
Yeah, it is okay to do MR. MR is good. But even you will not be looking for necrosis after 15 days. Within 5 to 7 days, you will be, it will be clear whether necrosis is there or not. So that's why they say you delay the scan for 5 to 7 days.
Yeah, but even after 5 to 7
days. MR is good. MR is very good.
Because
MR, yeah, sure, MR is good.
For MR, we have to give contrast or
no, you don't have to give contrast. But the only trouble with MR is it takes a long time. And also the patient is from the ICU. Then you have all the paraphernalia with the patient and you may not be able to do it. There may be, oxygen saturation issues. He may be intubated. He may not be able to lie still for half an hour. So those are the issues.
Okay, sir. So then what about imaging? Patient comes with suspected abdominal sepsis, creatinine is elevated and all these things. So what kind of approach we should have in imaging to find abdominal source?
So, one thing, so what I do is, first thing is ultrasound. Excellent modality, very good. And then followed by non-contrast CT scan. A non-contrast CT scan can tell you almost everything. If you combine X-ray, ultrasound with non-contrast, on ultrasound with the Doppler, you will be able to see the vessels. And with non-contrast, free air, bowel wall thickening, everything. So you can use these two modalities. And if you really do want to give contrast, you can go ahead and give a contrast called VisiPake, which is a little safer for the patient, and be ready to, do a dialysis if need be.
Right, sir. So finally, sir, what about the diagnosis of acute mesenteric ischemia? Because this is also something which you see and it's a very serious condition. So what kind of imaging and what kind of sensitivity, specificity do we have for acute mesenteric ischemia?
So in case of acute mesenteric ischemia, the patient will come generally with postprandial pain. But the patient could also have an Aplas syndrome or some other disease. So you have to do an angiogram. So in the angiogram, you start with the plain scan. Because in the plain scan, you find hyperdense bowel loops. It indicates that there is definitely ischemia. Then you go into the arterial and venous phase, and you will be able to pick up the obstructions in the artery or veins. And you'll also see the enhancement of the pattern of the bowel loops. Ischemic bowel loops will not enhance or will show delayed enhancement as compared to the normal bowel loops.
But is it always able to pick up, or sometimes you will miss?
No, in most cases you will pick up. What you will not pick up is NOMI, non-occlusive mesenteric ischemia.
Yeah.
That is very, those vessels are very small in the periphery. So that will not be picked up. But in those cases, surgery will not be done. Nothing will be done. Only medical management will be there. So it really doesn't matter.
No, but we have to diagnose her because
So
non-occlusive
you
is
will.
not
So
too
if your
rare.
large vessels are normal, and the patient is suspected to have obstruction, ischemia, then you are left with only one diagnosis, that is NOMI, non-occlusive mesenteric ischemia.
Yeah, okay, because this is not so uncommon because patient
Yeah,
has,
I understand. In the ICU, we see a lot of cases.
yeah, because they go into hypotension and they're already having
Yes.
atherosclerotic mesenteric
Right. So
vessels.
you also look at the hemoglobin and those things,
Yeah.
at the other inflammatory markers.
Right, sir. Okay, sir. So there are no questions from the audience. We thank you very much, sir. This is the second session you have taken, and we're really grateful to you. And your first session has been really useful to the students, and I will put this up on our channel, and the students can, and the other young doctors can review it. Thank you so much, sir.
Thank you very much. Thank you.